been working with Luke and Aaron for a little bit now, and then through that, seen a few of the guys from the gym here. So they got me in today just to run through just some real quick and easy stuff around backs and knees, some kind of common stuff we'd see in clinic. So not really any of the weird, wacky and wonderful stuff, but more stuff that you might see in clinic, especially in gym goers. So we're going to have a quick chat through kind of just pain first, common errors people see in training, and then we'll go through some knees and backs at the end. So really, the first thing is kind of what is pain? So pain is pretty much an output from the brain. So a signal has to come up from a knee or a back or an ankle or whatever, up to the brain. The brain has to decide what to do with it. And then part of that response can be to produce pain. It can do this with an injury, so you have some structural damage. You can do this without an injury, so you don't have to actually have hurt anything and you can get pain. The best way to think about that is if you put your hand over a flame, it hurts, take your hand away, you haven't burnt yourself, but it's hurt. No injury, but you can still have some symptoms. And what we know about pain is it's really complex and it's driven by a lot of different factors. So some of the things that go into pain, you have biological or physical factors, so whether that's an injury. You have some social factors, so they would include like your work, activities of daily living, coming to the gym, that sort of thing. Psychological, so we're talking stress, anxiety, poor sleep, and then some genetic components as well. And so really what this means is pain has a lot of different contributors, so it's really multifactorial, and we can't really just blame one particular thing. So we need to keep a bit of an open mind as to some of those other things that might contribute to something getting a bit stiff or sore, all right? We're pretty happy in clinic that low levels of pain are okay. So for the most part, we're happy for people to exercise into that 0 to 3 out of 10 range, and anything above that is usually a bit of a warning light to just change what we're doing, whether that's to modify an exercise or do something different. The reason for this is that, like that hand over the flame situation, pain is a bit of a protective response. So it's a bit of a warning system. So low levels is like the fuel light coming on in your car. You can kind of keep going for a little bit. And then this is kind of something we'd see happening a lot, and I think Aaron and Luke would probably see similar in here, is that we see people kind of stuck in this cycle. So something gets sore, you have an injury, elbow, knee, back, whatever. We reduce our function, so we don't do as much because things hurt. Some people, that means we just have a complete rest and we do nothing because nothing feels good. But what happens when we do nothing is we decondition, we lose some strength, we lose mobility. As a result of that, we reduce capacity. So what that means is we're reducing how much we can do before things get a bit sore again. So if our level of capacity has come down, we come back to training or we come back to exercise, the pain comes back quicker. So then we have rest again, we decondition, reduce our capacity, pain comes back quicker. So you can see it can very quickly spiral. And this is something we see when people have symptoms over a prolonged period of time, is they start to kind of really struggle with even doing quite light things. So part of getting on top of an injury is to try and break this. So we'll go through just some of the common errors that we kind of see, and this applies to all injuries. So the first one is training load, and this is probably the biggest thing that people make a mistake in, and it really comes down to too much too soon. So if you've had time off from training, so let's say you've been injured or you've been on holidays, you've been sick, when you come back into training, you have to stepping stone your way into it. If you make too big of a jump, the risk of things getting sore is quite high, and that risk is high for 6 weeks after you do it. So if you go, I've had a week off, I come back, I do 10 sessions in my first week, I'm at a higher risk of injury for the next 6 weeks afterwards. So it's quite a long period of time. So it is just about making sure you build up. So you build up number of sessions, you build up the weight you're lifting, and you give yourself time to improve and adapt. And that's kind of the safest way to go about it. Ignoring your body. So this is even simple stuff like I'm just feeling really flat, run down, fatigued, I had a crap night's sleep, work's been hectic, listening to that is important because that's when you're going to come into the gym and try and push really hard. Things are going to get a bit sore. So if you're having a bit of a down day, it's just chat to the coaches and maybe lift lighter on that session, pull back a little bit, and then that's going to allow you to then back up and train the next day and not pull up too sore. Not getting a diagnosis if something is sore is pretty important. We see a bit of, a bit on Dr. Google and, I think I've got this with my knee and I've been doing all the stuff Google says, but you've kind of gone in the opposite direction to what you need to be doing, and there's probably a reason why now you're still sore. So getting some feedback from the coaches or your GP, physio, whatever, but getting a bit of a clear picture of what's happening, so then you know what's good for it and what you should be modifying or avoiding. And the last one, which I'm sure I know Aaron and Luke have some challenges with this, with injuries, is let them know. If something's sore, something's niggling, let the coaches know. If you're having to miss a session or you think you have to miss a session because something's sore, let them know, because there's always stuff you can do around it. There's always ways to modify things. So, and if you think back to that cycle of injury, you'd rather not be skipping complete sessions. So you're better off to come in and do a modified session, a modified workout, so the rest of your body is still keeping condition to use and it's all not just deconditioning as a group. All right, so we'll get rolling on some knee complaints. Now, we're not going to go through a knee like this. I just liked the picture. But it's a good example of a knee that is moving in a direction it probably shouldn't. There we go. So there's a few things in and around the knee that can be injured and can be a source of symptoms. Has anyone here had a knee injury before? Yeah, fair few? Yep. So really, one of the first things we do in clinic is to determine whether the pain is coming from something outside the knee or within the knee. So a really common thing we'd see in the gym from outside the knee is patellofemoral pain, so it's pain from the kneecap. And then stuff that we might see within the knee, we're talking more meniscus or cartilage. Okay, so we'll run through those after this. One of the quickest ways to determine if, and this you can do yourself, to determine if my pain is coming from within the knee or outside the knee, is the presence of swelling. Knees don't swell for no reason. So if you have a hot, swollen knee, there's a fair chance that something internal is driving that rather than external. Okay? So if someone comes into me and says, oh, I've got this meniscus issue, and the knee looks absolutely fine, there's no swelling, I'm not really thinking it's meniscus unless they're in the bottom of a flare-up, so there's no real symptoms at the moment. But if they come in and say, oh, I've got this patellofemoral pain, I've been taping it, but my knee's fat and swollen, again, I think that we're probably missing the mark there, okay? And that's what a fat and swollen knee looks like. So it's not, oh, I think there's a little bit of fluid in there. It's pretty evident, right? There's actually a fair bit. And what we're looking for is, if you look to the knee on the left, the left knee, you can see the contours around the kneecap. And so on the right, there's no contours, it's just kind of one big thing. So that's what we're looking for. If you're losing the contours side to side, then you've got some fluid sitting in that knee. And the one on the left will be hot. So you'll put your hands on both and you'll notice a really distinct temperature difference. That's an easy one you guys can do yourselves. If you go, I've hurt my knee, is it hot and swollen? That will give you a bit of a baseline understanding of where your symptoms might be coming from. All right. So patellofemoral pain. This is probably the most common knee pain that we'll see, especially pain around the front of the knee. And it's driven from irritation of the tissues around and underneath the kneecap. It won't like squatting, lunging, kneeling, stairs, sometimes even cycling. So it's really anything that is putting load through that knee when it's bent, because that compresses the kneecap into the joint. And often you'll find deadlifts are still pretty comfy. So a lot of people say I can deadlift fairly well with no issues, but can't squat or do step-ups. And the picture here shows is they got a bunch of people with patellofemoral pain. They said, can you map where it hurts? And so it's quite widespread. So this is kind of like everyone put together. So there's no real one distinct spot. It can be anywhere above, below, to the side, underneath that kneecap. So anything that we see kind of around the front of the knee, we want to have a look at this. So in that acute stage, so if you're at the gym and today my knee's really sore, next session it's really sore again, I think it's patellofemoral. The acute setting is really just about calming it down. So we're trying not to provoke it, trying not to allow it to keep hanging around. So simple strategies, right? You would ice it, use some anti-inflammatories. Taping works really well in these settings. You modify your gym and training, so it might be doing a bit more deadlifts rather than squats. It might be squatting a bit shallower rather than really deep. Rather than doing the bike or the rower, you might do the ski erg. So there's lots of ways you can go about still training, but just offloading it for a short period of time. And some exercise is often good as well. So that might be some foam rolling through the quads and hips. You might do a bit of stretching, and even some light, easy quad strengthening that's kind of pain-free. And then if that's hanging around in the long term, now for me, long term is something that's probably been there more than a few weeks. This is when we kind of do all that similar stuff to that early stage, but then we have a bit more of an emphasis around some strength programs. So primarily we look at the quad, so at the front of the thigh. This is because our kneecap sits within the tendon from your quad. So whatever your quads do controls what that kneecap does. But then we also look at the hips and the ankle because that controls this motion. So the knee and the leg rotating in and out. So we look through that, we strengthen through there, and then we rebuild your tolerance into flex position. So it's deeper squats or the bike or the rowing machine where your knee gets quite bent up. Has anyone had patellofemoral pain before? Similar to this? Yep. Did you tape it? No. If you ever get it again, try taping. It's really good. And you've had some as well? Yep. All right. Knee OA. So this is probably not so much for the younger people. Maybe a bit of our older group. And so this comes from pain from within the joint. So this is our joint surfaces. So if you think about when you eat a chicken wing or a chicken thigh and you have the hard white shiny edge on the bone, that's the joint cartilage, and that's what it would look like within our knee. And OA is when that cartilage isn't as healthy as it should be. Okay. Usually with this, it's a bit more of a generalized broad knee pain. So it's not often really pinpoint. People feel quite stiff. So they'll wake up in the morning, the knee will feel stiff. There'll be swelling. And like I said, typically it's more common over the age of 45, but younger people do get it. And we're seeing more in younger people because we're seeing more injuries such as ACLs and meniscus tears from sport. And that puts you at a higher risk of early arthritis. The other thing that's probably interesting about arthritis, and you're going to hear me talk about this a bit in a few of the other bits and pieces, is that a lot of people will have arthritis on their imaging, on their x-rays and scans, but won't necessarily have symptoms. So we know that you can have changes, so you can see on the x-ray here, I wonder if you can see. So you can see along that side there, we've lost a little bit of space compared to here, where there's a bit more of a gap. So that would be arthritis in that section there. So we'd look at this x-ray and we go, right, this person has arthritis. But you might talk to them and they say, my knee's fine. And we see that a lot. So it is about correlating the imaging to how you present. And that's for pretty much everything that we in the body at the moment. But that's what it would look like. So so it's making sure you don't get too caught up if you have an x-ray or a scan and it says there's some arthritis in the knee. It really comes down to what you experience. So management for this, and Luke and Az would love this. So this is kind of a pyramid, a hierarchical structure of what people should be doing with knee arthritis, but this also applies to any arthritis, so hip, back, shoulder, pick your poison. Everyone, so the green at the bottom, that's every single person should be undertaking education, exercise, and weight control. So exercise is a mixture of cardio and strength, but really strength exercise, so resistance training is more important. What we're trying to do with that is to offload the sore part of the knee. So that part of your cartilage that's a bit grumpy, we're trying to get the force away from that. So if your muscles are stronger, that cartilage doesn't have to work as hard. And we're trying to keep the remaining healthy cartilage healthy. Okay, they like movement. Primarily around the knee, we're talking quads, hamstrings, but then looking at kind of glute and trunk as well. Weight control is really important in the lower limbs, so we're thinking knees and hips with arthritis. If you lose a kilo of body weight, that's 10% less load through the knee. It's a fair bit, right? So the more we kind of, if you have a knee arthritis and you're losing weight, that's going to go a long way to helping that feel a bit better. As we go higher up, you can see some people will use pharmacological pain reliefs, that's painkillers, anti-inflammatories, passive treatments, so that'd be soft tissue release, needling, cupping, that sort of thing. Aids is kind of braces. And then at the very top, only a few people should really go on and have surgery for knee arthritis. Okay? All right. Any questions about that? Nope. All right. So meniscus injury. So the meniscus we can see on the picture are those kind of highlighted in blue. They act as shock absorbers within the knee. So the femur comes down and it has kind of two grooves like the edge of your knuckles, and it sits on a flat platform from your shin. And what the meniscus do is they cradle those grooves from your femur and help spread out the force through the knee. So it's not really pinpoint pressure, it's a bit more broad. We obviously have a medial and a lateral meniscus. They're two separate bodies. And injuries in these, we break down into an acute meniscus injury is I've twisted, my knee's hyperextended, or had a bit of an accident playing footy, and I've now had this acute swelling and pain. Long-term ones are usually just slowly started to get a bit stiff and sore and swollen. And our management for those is fairly similar, but sometimes the acute might have surgery a bit quicker. And we also do see it more in males at the moment, but again, with the increase, especially in Australia, of women's AFL, we're seeing more in women, so I wouldn't be surprised if we see that swing to see more women with meniscus injuries than men. And I think everyone here would probably know someone who's had surgery for a meniscus issue, right? And a lot of people have an arthroscope or a keyhole surgery. So in the past, yeah, we probably would have sent most people off to have surgery, right? We'd say, meniscus, go get it looked at. Now, for the vast majority of people, we don't recommend this as the first point of treatment. And part of the reason for this is there's been a handful of really great studies where they got a bunch of people with meniscus tears, and they signed all the paperwork, they knocked them out. Some people had an arthroscope and they either removed or repaired the meniscus. Some people, they just cut their skin open and stitched them back up and didn't do anything within the knee. No one knew what they had. They all, after the operation, did a period of rehab. Everyone got better. Wow. Yeah, so we kind of go, okay, so maybe it's not the answer for everyone, right? That doesn't mean we don't do them. There's definitely scope to do knee surgery for meniscus tears, but we shouldn't just be rushing into them. We need to pick our person a little bit better. And the surgeons on the Gold Coast are getting better at not just operating on everyone. I won't say all the surgeons, but the good surgeons are getting better at not operating on everyone. So what do we do instead? So we kind of follow those real simple principles of we want to calm it down. We want to get rid of some of the swelling, get rid of some of the pain, get some good movement back into it. And then we want to get it strong again. So similar to arthritis, if we can have a bit of a stronger muscles around our leg, we will offload that meniscus. If we can do some stability work, we will help reduce some of that rotational force and maybe some of those risk factors for hurting it or injuring it again. And so really, gym work becomes important here. So that's one of the biggest challenges we often have with people who don't come from the gym, and they come in with a meniscus injury or a knee OA, is to get them into some sort of gym work. right? Because that's in the long term a lot more beneficial than anything else. And then, like I said, sometimes the acute injuries will have surgery sooner. And this is usually if they're having ongoing episodes of instability. So the knee is buckling and dropping away from them. And then there's certain types of tears that will also have operations sooner. If you injure your meniscus and your ACL and you decide to have surgery, they will always repair the meniscus if you do your ACL as well. All right, any questions on knees before we jump into backs? Nope. All right. Who here has had lower back pain? Yeah, good. So if you kind of have a bit of an idea, it's really common, and it's just about as common as the common cold, right? So we kind of probably need to approach it that way. At any one point in time, 50% of people will have back pain, right? So right now, and it's over 70% of people in their lifetime will experience back pain. So it's pretty common, right? It's pretty prevalent. The vast majority of new episodes of back pain will get better in 4 to 6 weeks, right? So if you hurt yourself in the gym, regardless of how severe that pain is at the start, within 4 to 6 weeks, the vast majority feel pretty good. It's really quite rare to have anything serious or sinister happening with your back. So we have like 98% of cases are okay, and there's that really small, probably 2% that is something serious going on. So what we'll do, we'll kind of similar to the knee, we'll break it down into acute back pain, so a new episode, and then we'll talk about some of that longer standing back pain as well. So with acute back pain, we kind of need to think about what have we injured. Now, it really comes down to a few different things, and I guess in terms of how you present, but we kind of approach and go, right, primarily it's going to be soft tissue. So we're thinking muscle and we're thinking ligament. So we approach that like a muscle strain, same as a hammy strain or a calf strain, or ligaments, so like an ankle sprain, right? So with a calf strain or an ankle sprain, what we do, we'd have a couple of days taking it a little bit easy, and then we start to walk on it and get it going, and then we get back in the gym and we start running and it feels better. We should manage backs the same, okay? So we have a couple of days just to let some of those pain and symptoms settle, and then we should start slowly getting going again. Too often we probably spend too long waiting for it to feel better before we start, but if we have a pretty good idea of what's happening, it can be really safe and probably more encouraged to get moving sooner rather than later. And then, we often sometimes see, it's not as common, but we can see some disky and nervy sort of presentations. They present really different to your usual, I woke up and I'm a bit stiff, or, it's a bit pinchy when I arch or when I bend. These will stand out. Disky back pain in the acute setting, you really probably can't move a lot. It's really quite stiff and sore. And nerve pain, obviously, you're going to get something down into the buttock or the legs. Maybe some tingling or numbness. Again, the initial management is the same. We want to just give yourself a couple of days, calm it down, and then start to get moving. The main thing is, if we think it's disc or nerve, it's maybe just going to be a little bit slower. That's all, okay? We know that for the most part, these will get better. Even when you have tingling and numbness, again, be a little bit slower, but most cases it will get better without having to do too much extra on top of that. So then we kind of need to ask, why do these acute episodes happen? So why does my back get sore? So sometimes we can pinpoint it to a specific thing. So I banged up my weight in the gym and my back was sore mid-lift, right? Or I went and played, I got really stuck into golf and I played 18 holes 3 days in a row and then my back's sore, right? Like, people do this, and that's a really clear relationship. We go, okay, well, here's something you've changed. Here's why your back is sore. The other group we see in the acute setting is when you just like, I woke up, my back was sore. Or I bent over to tie my shoes and my back kind of grabbed and now it's really sore, right? And we go, well, that's a really kind of trivial event. There's not a lot of load in that. So why does this happen? And this is when we need to think back to right at the start when I spoke about kind of all the different things that contribute to pain. So in this case, we usually have to go, okay, well, there's probably a few other things that are contributing to this. And I use the analogy of filling your cup. So there's everything in life starts to fill up your cup. So whether that's work stress, whether that's poor sleep, diet's been really crappy, I've been out in the town, I haven't been training and I've come back to training, it slowly fills your cup and then eventually something makes it overflow. And that can be something really trivial, like bending down to tie your shoes. So it's not bending down to tie your shoes that's the issue, it's everything else that's kind of come into it. So when there's not a real specific episode or a cause for your back pain, we need to cast that net a bit wider and start to look at some of those other things, okay? And you'd be surprised how many people will develop back pain just because they've had a week of crap sleep and work's been really stressful. And then we have back pain that's been on for the longer term. So this, similar to the knee, it's a few things going on. We'll have a bit of reduction in capacity around the back, so that's some strength and endurance measures. And that's not just our abs. Everyone thinks core strength, just get your abs really strong. We need to consider the whole picture, the sides of our trunk, our actual back muscles, the works. Stiffness and tightness, so whether that's the back itself, those joints aren't moving really well, or we're looking through our hips or our upper back, and that's why our lower back is working harder. And then altered movement patterns. We see people with ongoing back pain do some really funny things when they move, and often not helpful postures and positions as well. So some people come in, they go, every time I bend backwards, my back hurts. But then when I do a squat, I squat with my back really arched. Well, it doesn't really make sense, right? So part of that is to train and retrain positions so you can hold your back in somewhere that's a bit more comfy. And then, like I said about knees, and some people have imaging in the knees and it shows arthritis and they don't have any knee symptoms. So what this is it shows in years, going left to right, imaging results of people who've never had back pain in their life, okay? So we look at people in their 30s, 40% of people in their 30s, so up here, have a disc bulge, but no pain. And as we age, everything gets more. So we get to our 50s, it's 60% of people and beyond. If we look at disc degeneration, in 50% of people in their 30s will have it on their imaging, but zero back pain. And everything climbs as we age. So what does this mean? It means, again, we can't get caught up in what our scan says. We need to link the two together. So if you come in with imaging done and you have some back pain, we need to put 1 and 2 together, okay? Imaging doesn't tell us what's sore, it just tells us what's there, right? If I showed you a picture of a telephone, could you tell me if it was ringing? You can't, you say it's a telephone, right? So it's the same thing with x-rays and scans. We can tell you what's there, but we can't tell you what's ringing, all right? What we do view it though is that if you have this on your imaging and you don't have back pain, maybe it's a risk factor. You might have a higher chance of getting a sore back at some point, but not guaranteed. All right, so the key back pain takeaways, don't be too concerned about it. The majority of cases are pretty okay, and the majority of cases will get better in 4 to 6 weeks if we keep active and keep moving. Don't get caught up on your imaging. We need to put 2 and 2 together. Motion is lotion is one of my favourite sayings. Keep active, keep moving, and it's just modifying what you do, but there's always a way to keep going. And get some help along the way. So, chat to Az and Luke, use your GP, use your physio, use your myo, use your chiro, whoever. But get some help. Get some help to get going, get a bit of some guidance around a bit of a plan for what you can do. And I guess then the key thing across backs and knees, and really anything we see in clinic, follows this principle. We just calm it down, get it to feel a bit better, and then progressively build it back up to what you want to do. So whether that's work, being able to drive for 3 hours without back pain, deadlift 100 kilos, whatever it is, calm down the symptoms, and we progressively build it back up. So really it's the KISS principle, right? We don't have to overcomplicate it. Okay, done. Any questions? Got through it a bit longer than half an hour, so I apologise for that.
I might just ask one, just because I've had a tear in my meniscus.
Yeah.
So it was about 12 months ago now, I suppose. and I haven't had any surgery. I'm just sort of waiting. It will just heal itself together.
Not necessarily. Not necessarily. It depends on the section of the meniscus. So some parts have good blood flow and some parts don't. But we don't really need it to repair either, right? So really what for you need to be looking at is go, well, what do I feel in my knee? What symptoms do I get? And how much function do I have? So am I doing everything I want to do and my knee copes? That's a pretty good outcome, right? And if you saw a surgeon privately, they wouldn't operate for that. But if you go, look, I've been doing 12 months of rehab, I'm getting really strong in the gym and it keeps just having issues, well, then that might be a different story. But we don't need that tear to heal, and we can't guarantee it'll heal by itself.
Slightly off subject.
Mm-hmm.
What if it was to pay better music while working?
Yes, absolutely.
Did you feel that?
Country western only. Cool. Any other questions?
I had a Baker cyst a couple of years ago
Mm-hmm.
that burst, and they said that the Baker cyst was created by flooding in the last cartilage in the knee.
Mm-hmm.
So now that that's healed, I still get that sensation of the when the Baker cyst first developed when I'm training. Is that a normal sort of?
Yeah, so a Baker cyst is when you have that joint capsule and that holds all your joint fluid in place. And the Baker cyst is a little projection of that. So if you have too much fluid because there's a bit of swelling or inflammation, sometimes it pushes out and that makes a Baker cyst. So even though it burst, it will heal up and you might have something small sitting there, which is why you might get some feelings as if it's starting. Yeah, so that would be fairly common. If it's really bothersome, you could chat to your GP about it. But if it's there and it's just it's a bit annoying, but I can cope. Just keep the knee really strong. Ice it as you need. Yep.
I have a question. If someone gets back into running, which is a common one, they experience some kind of back or knee pain, just getting back into it, what would your advice be around that?
Yeah, it'd be look at a bit of running technique. So have a look at, are you just plodding along and everything's twisting and turning more than it should? So have a look at technique. And then if you're still having issues with that, then I'd be looking at some of your mobility through hips and back, and then how you control that movement as well. So are you just flopping around because you've got lots of movement, you can't control it, or are you really stiff and you actually just can't move your leg behind you that well? So it'd be a bit of a mixture of either some mobility check, technique check, or then it's just some strengthening.
What are your thoughts on ice or heat, like the knees or backs? What's better?
I always like heat for backs from the get-go. I haven't met a single person that likes putting an ice pack on their back. It's probably not the nicest of feelings. And because in that acute setting of back pain, a lot of that pain is driven from muscle spasm. And so we don't want you to tense up more. We need the back to relax a little bit. So heat around the spine, so back and neck. And then out in the periphery, so hips and shoulders and beyond, I like ice in the acute stage. And then if it's been hanging around a little bit longer, I'm a bit open to hot or cold, whatever kind of feels better.
How long should you use it for, like acutely or?
Yeah, so in the acute stage, if you have an acute knee injury, I'd be getting people to ice it 20 minutes, and really if they can do every couple of hours would be good. And I keep that going until really the swelling's gone. As for heats for a back, as long as you don't burn yourself, just as long as you want, sort of thing. We get people you can get stick-on heat patches from the chemist. We'll give you like 10 hours of heat that you can wear all day at work. And then, I'd keep icing a knee or ankle or whatever until pretty much swelling's gone. It would usually be a couple of weeks.
For my lower back, I've got like a stretch routine that I do in the morning, but a lot of it's like static. Do you think static stretching is better or more some mobility work?
Chicken or the egg? Yeah, personal preference, right? I guess it depends on what you're trying to achieve, but if you like the feeling of static stretching and it feels good afterwards, if it's not broke, don't fix it. Yeah. Some people really don't like static stretching. They get bored. I get bored of static stretching, so I go to more movement. But that's just me. Yeah, so either or is fine. Yep. Yeah.
In regards to stretching and whatnot, for even stretching your legs if you've got a sore back and stuff. The stretching versus the roller or the ball. There's stretching that stretches that muscle, but the ball tends to get in and sort of apply pressure on things.
Yep.
Do they do the same thing, or
Similar. Yeah, similar, like similar but different, right? So both can give you some nice changes in mobility in that short term. So you can do some trigger work, or you can do some stretching. You can go, well, now I can, say, touch my toes, for example. In the long term, stretching might make you a bit more flexible than rolling, but both can help with pain. So if your goal is to go, like, I want to be able to touch my toes, we've probably got to stretch, right? You can't just roll your way to that. But if your goal is to just go, I just want to feel a bit looser before I work out, either or. Yeah, so you could use a roller, a ball, a massage gun.
Like before I go for a surf and I'm home, I'll do a bit of a stretch, but then getting on the roller and getting the ball again in the butt really makes it go much better.
Absolutely.
As opposed to just going for a stretch or just, so they can work. You do work.
Yeah, if you're looking for a short-term change, both will work. If you're looking for a long-term change in mobility, you've got to probably do a bit more stretching. Yeah, but if it's just pre-surf, bit of a warm-up, loosen up, absolutely. I'd jump on the roller.
And the cool down stretching and rollers as
Yeah, especially if you have a little niggle, post-training, just a bit of a longer, you might do a bit more static stuff then, or a bit of a lighter rolling routine, but it also helps with some recovery between sessions as well.